Our next speaker is Dr. Bernard Goldstein, who also was not able to join us in person because of the weather. Dr. Goldstein is the former dean of the University of Pittsburgh Graduate School of Public Health. He's an environmental toxicologist whose research interests have focused largely on the concept of biological markers in the field of risk assessment. He is currently faculty emeritus for the University of Pittsburgh Schools of Health Science. Dr. Goldstein has published in the areas of blood toxicity, the formation of cancer-causing substances, free radicals, following exposure to inhalants, various aspects of public health decision-making, and global issues in environmental medicine. He also has served as an officer with the U.S. Public Health Service and as Assistant Administrator for Research and Development at the U.S. Environmental Protection Agency. Dr. Goldstein received his medical degree from New York University and his undergraduate degree from the University of Wisconsin. Welcome, Bernie.
Again, I'm like the others who couldn't be there. I'm really sorry not to be with you and sorry to have missed what seems to have been a vibrant meeting. Let me thank you for including health in the discussions today and to giving me the job of explaining about academic health and its role and potential role in response to oil spills and similar disasters. Can I have that first slide, please? Or I guess it would be the next slide showing the Gulf State Health Indicator rankings. Before I discuss academic public health and what has been happening in this area, I thought it important to give the setting. Just as in ecosystem research, we try to recognize what the local settings are, we need to, in any health research, understand what the community health indicators are. And as you can see, the area affected by the Deepwater Horizon, the citizens do not have the best health statistics. In fact, they are pretty poor in terms of the usual health indicators. And this is something we can't lose sight of. These are communities that are at risk. Next slide, please. In terms of schools and programs of public health, it's one of the more rapidly growing areas in academic pursuits, and so there's a rapidly growing number of them. The slide should be showing you the members of the Association of Schools and Programs of Public Health. There's over 100 of them right now that are accredited. The following slide has the 5 core discipline areas of public health. I put that in there to make it clear to everyone how diverse the field of public health is. These are 5 areas which we must have for our accreditation. One is environmental health sciences, and as a former dean on a campus, I can assure you that I frequently pointed out that we are the only school, at least at the University of Pittsburgh, which requires environmental health sciences graduate education for our accreditation, for our national accreditation. But biostatistics is applied mathematics. Of course, in environmental health sciences, we have a laboratory component. Epidemiology brings in more clinical areas. Health policy and management has economists and policy folks. Social and behavioral sciences has psychologists, sociologists interested in the perception of risk and how people respond. And our mantra is basically that there are no major public health problems that can be solved by any one discipline working by itself. So that, if you put up the next slide, that clearly brings us into attributes of sustainability, which I think this audience is very familiar with. And public health, too, is something that we believe has, in some ways, already incorporated some aspects of the sustainability approach, and it includes the multidisciplinary approach to problem solving, the importance of developing trade-offs and synergies among the sustainability pillars. Trade-off analyses is inherent in the practice of public health. The temporal, multi-generational approaches. I see I listed focus on maternal and child health, but left out my particular concern, which is aging. There's the global dimension, and obviously the anticipation and prevention of disasters dating back to, at least in my area of the country, the Johnstown flood and other areas of this nature. Resilience is, again, something that we sort of understand intuitively. You can think of vaccinating people for flu as being, if you will, increasing not only individual but also community resilience. The next slide, I want to expand on the point of the anticipating and preventing disasters. What you should be seeing now is the classic picture of an oil rig on fire. We don't call that an accident. We call that an incident. In fact, when we get together and talk about these kind of issues, if you say the word accident, you're supposed to put $1 on the table and it goes into a pot. And I've put many dollars because that is the common way of putting this. The next slide is my attempt to show what an accident might be. It's a comet hitting an oil rig. But we think of these as completely preventable and based on an approach that is very familiar to engineers, to systems people. You assume that zero is the right goal. And so there's a fair amount of work on just that kind of approach in public health. Again, it's a broad area. It refers to our goal for a number of people who fall out of bed and hurt themselves in a hospital or a nursing home should be zero. It was a relatively rapidly held Institute of Medicine workshop on assessing the effects of the Gulf of Mexico oil spill on human health. The next slide, I've put together some of the take-home points, just a few of them that came out of that workshop. Again, the issue of safety culture, the importance of exposure assessment, which I think leads us into an area of important research as we plan for the next disaster. From exposure assessment, it is central to linking chemical toxicity and effect. And it's just not just what is being released and trying to then model what might get to people, but what people are actually being exposed to is something that should be relatively high on the need to understand what the impacts are and to develop the information that the public needs to respond. Because psychosocial impacts not only may predominate, but in my view probably have predominated in the Deepwater Horizon response. And that's not to belittle them. They're real. But we do need to understand what the public is concerned about to be responsive. And certainly it's something that, in terms of lack of trust or transparency, Admiral Allen, Dr. Lutchenko have pointed out to the importance of these issues already today. Risk communication must be tailored to community understanding. In other words, it can't be our language. It's got to be language that the community understands. And obviously, seafood safety is of great importance. The next slide, please. The reason I'm involved is I was asked as a member of the Institute of Medicine to go and write something for the New England Journal of Medicine that reviewed oil spills in relationship to the Deepwater Horizon. And what was pretty clear is that as you look at the world's literature is that we know far too little. This is my coworkers and my colleagues and I, Howard Osofsky of Louisiana State University, Maureen Lichtveld, who I know is there, of Tulane, ended up with a summary summarizing our findings. It's basically that the initiatives needed include rapid development and implementation of protocols for baseline clinical evaluations, biospecimen banking, short and longer-term medical surveillance and monitoring of workers, and development of psychosocial interventions, especially for vulnerable populations. The next slide just has one example of an unnecessary stress factor that needs to be reconsidered on a level of policy and law. This is the dispersant. As you'll see at the bottom, there's an organic sulfonic acid salt, which was listed as proprietary. If you do, as I've done in the Gulf, my colleagues have done, ask people about that. Do they know that there was a secret ingredient in the dispersant? They will say yes. And if you try to ask the question of does it concern you, there is a great degree of concern, and not surprising. We all know that secrecy impacts on stress, that risk perception, that transparency the lack of transparency is something that does a social amplification of risk. In this case, it turns out that unknown secret ingredient is probably the most commonly sold laxative over the counter in the United States. As a physician and toxicologist, I'll tell you, I'm really not very concerned about human health impact of something that 1 million doses a day are used. I don't know what it does to the fish, or to the ecosystem in general, but certainly there was no reason for this secrecy, and any of the competitors of the company could figure this out with probably $10 worth of analytical evaluation. So the reason for the secrecy is not, there is no reason, and it's inappropriate in terms of the stress that it caused. We need to be aware of that and see what we can do about changing that. The next slide shows a paper in the New England Journal of Medicine on research as a part of public health emergency response, which does consider the Deepwater Horizon. The authors are Nicole Lurie, who's the Assistant Secretary of Preparedness from Department of Health and Human Services, Francis Collins, who heads the National Institute of Environmental Health Sciences, Thomas Frieden, who's the head of Centers for Disease Control, former Commissioner of Health in New York City, and others. But this is a group that's basically for health equivalent to a group that published 2 superb papers in PNAS. One headed, the first author is Jane Lubchenco. It's Science in Support of the Deepwater Horizon Response, and the other is headed by the first author is Marcia McNaught, and applications of science and engineering to quantify and control the Deepwater Horizon oil spill. As pointed out in these superb papers by excellent leaders of all of the different groups that were involved except health, there was no involvement. They do not really consider the social or health impacts related to the science that is needed. Others did that. So what we have is basically 2 superb papers in PNAS with the leaders of the field, a paper in the, again, an excellent paper in the New England Journal of Medicine, one of the health area's leading journals, by, again, the leaders in the health area. And what we really have to hope for from this Montgomery initiative is that if there is, when there is the next spill and the next sort of papers of this nature, not only will we be able to show that we're farther ahead, but that we will include in the health area, we'll have the leaders of the other areas also writing with us, and vice versa, that there should be a leader of one of the health agencies who combine with the leaders of the other agencies that were involved in writing the kind of papers that have to do with science and support. So what was done? The next slide is an intramural program of the National Institute of Environmental Health Sciences. It's a prospective study that's going on right now, trying to understand what happened to the oil spill cleanup workers. Unfortunately, and I'm sorry, I probably skipped this slide on the Deepwater Horizon oil spill by the, again, from the same paper headed by Nicole Lurie, where they talk about there were no uniform systematic collection of baseline data through surveys and biospecimen archives. In other words, we weren't prepared for this. The next slide is about the NIEHS Gulf Study Cohort, the intramural program, and I think the lack of preparation really has affected this study in that, as the people who were running it will say, despite it being a superb study, it got into the field very late. It didn't get into the field for the following January. As someone who's worked on developing biological markers of exposure through the years and of effect, for instance, on benzene, any biological marker of benzene exposure from the previous summer will be gone by the time you get into the field in the following January. We need to be prepared to be able to respond more quickly. In addition, in the next slide, the NIEHS has put together a research consortium in which the studies are examining the long-term impact on Gulf Coast residents and communities. This is a community-based participatory approach. Community engagement is crucial to this, and in my view, looking at this from a distance, the programs involved have done an excellent job of starting out with community engagement. The next slide is a map showing the location of these consortia. And a program which I have been involved in is shown on the next slide, which is the Gulf Region Health Outreach Program. This comes out of the medical settlement funds, and it's $105 million, which is aimed at improving the resilience of the communities by improving their public health so that they're better able to cope with the subsequent problems that might occur. It has 5 universities involved, a Louisiana Public Health Institute, which works with the state public health programs, and the Alliance Institute, which provides an umbrella for community organization involvement. This program does not do research, but in fact all of its interventions and all of its evaluations are going to be evaluated in depth and will be submitted for peer review. So in a sense, there is a research component. The next slide shows how it is puts together mental and behavioral health, primary care, and environmental health, groups that have not usually worked together in communities with the hope of making the communities a place that where community members do not have to go separately to get environmental health information from primary care, from their mental health and behavioral health support. Finally, my last slide, I want to point out how common this problem is of having health being separate from other approaches to potential environmental threats. This is a study we did looking at 3 major advisory committees, which in 2011 were put together to look at the shale gas issues. One is President Obama's, and as you'll see, I've emphasized the issues having to do with public health. Another is the governor, the Democratic governor of Maryland. The other is a Republican governor of Pennsylvania. All 3 in their executive orders talk about needing advice on health. Of the 52 members of these 3 advisory committees, the amount of people with any health expertise whatsoever, not only physician, nurse, pharmacist, but toxicologist, risk assessor, the amount of those 52 who had any sort of health background was 0. I'd like to think of Gomery taking the lead of making the necessary multidimensional approach to respond to public health concerns by including the health dimension to the advisory process and the research process. Thank you very much, and I'm looking forward to questions.